Good afternoon, friends. David Wright here, and I'm your host of the Disruptive Innovators Champions of Digital Business podcast. And this morning, I am lucky enough to be joined by Dr. Doug Bruce. Doug, how are you, my friend?
Going well. Good morning.
Yeah, great to have you. So Doug, Dr. Bruce, for our listeners who may not be familiar with you or your body of work, can you just tell our listeners a little bit about, who you are, where you are today?
So I trained in medicine at Parkland Memorial Hospital in Dallas in the 90s during the AIDS epidemic. And that actually really got me interested in groups that were marginalized that didn't really have access to the care that they needed. Lots of things happened in the AIDS epidemic. And part of my way of processing some of that was I went to graduate school. I started thinking I might be interested in biomedical ethics and particularly the rights of marginalized groups like substance users and the right that they have to get excellent care. And in that process, I moved to New Haven, Connecticut. I went to grad school. And in the process of that, started working with some great folks at the AIDS program. And then really just kind of latched on to more, how can I help support substance users, marginalized groups to really get the care that they deserve. And so started actually doing a research career because, when you're not sure what you're supposed to do, you should ask questions and get data and do research. So I started to do that. Got a little frustrated with the fact that things that are discovered in research don't always make it to the bedside and to the patients that need them most. And so started to kind of drift away from research to program development and had the opportunity to support work in Ukraine, this was years ago before the war, and in East Africa, Tanzania and Kenya, and in Ethiopia, to really start trying to think about how do you design novel ways to bring evidence-based care to the people that need it most. And so that just kind of really got me excited about system change and how do you make a difference in the world and the people that you're with. And so kind of fast forward, came back stateside, worked in kind of public health systems, and really became increasingly interested in the digital space because there's so much potential, but there's kind of this grand irony. A lot of what we do in the face-to-face interactions with patients is the same as it was in the 90s when I was charting on paper, right? The kind of interaction we're having. The difference is that now there's this computer that's involved in the room. And a lot of medical people view the computer as the enemy, right? It's my liability. It's not my asset. And so I started to increasingly think about, well, wait, the computer should be an asset. It should make things easier. It should help with documentation. It should help make sure that I don't miss that abnormal lab that's sitting out there. It should help me with patient safety. It should help me with identification. And so that kind of moved me from New England to Northeast Ohio to start really collaborating on the operations side of the house. How does operations work collaboratively, informatics, with the faculty to start to re-envision that connection between the provider of care, and the technology provider, and how do we actually make a better system of care delivery, right? Instead of, we'll just do what we did in the 90s. We'll take the piece of paper and make it a Word document in the computer program, the electronic health record. The 21st century, my phone is smarter than every computer I used in the 90s, in the 2000s, right? So why isn't my interface with electronic health record better than it was in the 90s? So that's kind of where I landed.
Lot to unpack there. Because I know we've talked a couple times. I didn't realize that the work that you had done surrounding, you mentioned the AIDS epidemic, you mentioned substance use disorder. I'm really passionate about that as well, per my mom's nonprofit, what they're doing with trauma-informed care and, changing the way we treat substance use disorder in the state of New Jersey and hopefully soon to be beyond. So yeah, that's really cool. I mean, it's so important, such important work because substance use is a symptom, right? It's not a people that use substances are they have been traumatized more often than not. There's something there, and the use of a substance is just a coping mechanism, an ill-fated coping mechanism, and it more often than not they have a chemical disposition that perpetuates that use. So it's just and so often it's mistreated too, right? Which is a shame. Like I think that nationally there's a lot of issues with a lot of the ways that we treat substance use disorder. So anyway, the fact that you were working towards that, I really appreciate, and what you said about the way that we're using technology, and what I heard was really to just to improve the human experience, right? To use it as a tool to be able to connect more and become an asset rather than a liability. I love that. So you've had a really interesting journey, Doug. What would you say is one of the most important things that you learned? And it could be personally, professionally, or otherwise. And just if you're thinking about kind of what life was like before that and after that, maybe you could just share, what comes to mind.
I think one of the biggest things that I've had to learn over the years is certainly everything in healthcare comes down to behavior change. And a lot of healthcare has mistaken the behavior change idea as a rational information kind of transactional conversation, right? You have diabetes, stop eating sugar, take these pills. Like, we're done. I've told you what to do. You should go do it. Fine. You come back, you haven't done it. Oh, you're bad. Like, maybe you didn't understand. I'll give you more education. So most of medicine then is this assumption that people don't change behavior out of ignorance. And that's a hallmark of how medicine approaches people. And I think that's fundamentally wrong. I mean, I'm not saying you don't need to be educated. You should know what diabetes is. But people aren't struggling in their diabetes often because, I didn't believe the doctor who said that diabetes is the leading cause of blindness, but I don't have transportation. I can't leave my job. I can't, I was late to the eye doctor and they canceled my visit, right? We're not really factoring in what does it mean for me to prioritize my health. I've got kids, I'm a single parent, I'm homeless. And so working with people who use drugs, working with the homeless, I learned a lot about how challenging it is to make any change. Changes that I would have thought were easy. It's like, well, if I'm better resourced, if I'm whatever, those changes might be easy. But then I had to stop and say, well, actually, kind of shame on me. I might even have more education on this disease, but I'm struggling. And I learned that in the AIDS epidemic too, when we would have we'd have residents who would be all upset and like, oh, why doesn't he take his pills every day? And I'm like, look, do you have to take something every day at the same time? Do you have to take something multiple times? So we would challenge them. Get a bunch of jelly beans. I want you to take like a green one every day in the morning, take a yellow one at night, and see how you do. And invariably, any honest consumer would be like, yeah, totally forgot. Oh, but then that's because I'm a resident. That's because I'm tired, right? We all have excuses for our behaviors, but that's the hallmark. It's like, yeah, you have a reason for what happened. The patient has a reason for what happened. And so I feel like more and more where healthcare needs to move and where I would love for technology to help is to help remove some of the documentation stressors that support the transactional relationship, right? Okay, I've got all of these checklists. Let me check off you're this, you're this, you're this. It's just transactional, right? It's not really a conversation. It's not a relationship. But behavior change is about a relationship. And this really hit me when I was there are better Hep C treatments now, but 15 years ago we were doing old Hep C treatment that made people really sick and depressed and lose their hair. And I remember, a person who uses drugs just looking at me saying, well, I really don't want to do this treatment, but you tell me that it's important to do it and I trust you. And I thought, well, wait, like this person is reprioritizing, like, and then these were, the treatments are now 8 to 12 weeks. This was 48 weeks of treatment, right? This was like, you're going to be miserable for a year. I'm willing to do it because I have a trusting relationship. I'm willing to change my behavior, not because it's transactional, not because you told me, well, if I don't do it, I'll get cirrhosis and die. Like, not because of all of these other data-driven pieces that people think change the calculus of my behavior, but it's because of this relationship that we have. And as I kind of moved on through life and started reading more about behavioral economics and about how people don't really make rational decisions often, right? We make these kind of emotive, heuristic responses to the things that we encounter in life. And then we kind of go back later and justify what we did. Started to make more and more sense. Man, in medicine, I need to focus on how to help people, how to kind of, or in the words of Richard Thaler, how do I nudge people? How do we change the choice architecture to help people make better decisions, not in a paternalistic way, but understanding that it is incredibly hard to change your life for some weird future probability. If you don't do this, you have a 10% chance of dying 6 months earlier, 15 years from now. Like, nobody knows what makes sense of the information that physicians provide sometimes. So it was like a long answer to a short question.
No, I mean, like, so good though. I'm trying to think of where to start. I mean, what I heard too was like, how are we making treatment and medicine more personal, right? Like, how are we creating that 360-degree view of the patient? Like, they're not just their diagnosis. It's those other factors that currently don't live in the EHR, right? Like, they're just not, there's not a space for it there, right? And it's hard to access, because like when you're seeing so many patients, like how are you making it easy to recall all of that and really spending the time to get that data in the first place? Like, it's a tricky paradigm, but I think about like going back to substance use disorder, like in the 40s, Dr. Silkworth, an Ohio doc, like wrote about the fact that like it wasn't like alcoholics and addicts, like they couldn't solve their issue with sheer willpower. Like the behavior change had to come in a perspective shift. And we've seen that serve millions of people that suffer from substance use. But it wasn't just like, hey, stop doing that. Like, here's the knowledge of how much this drugs and this alcohol is affecting you. Now stop. It required something else. And like when you mentioned this diabetes example, right? I like above and beyond like transportation. I like wasn't thinking about that either, or like other socioeconomic factors. Like, what about the guy who's, you know, addicted to food as a coping mechanism for trauma he experienced as a child, right? And like, how are like, so to treat something like that, I need to treat the trauma, not the eating, right? And then the eating will follow. But if I'm not treating the underlying, issue, it's even if I do something temporarily, it's likely to resurface in my
Oh,
experience.
it's so true. I mean, think about in the obesity world, right? That people can do surgeries to help do weight loss, or you can take a medication and get some weight loss. But people are able to still gain weight even after these things are being done, right? So to your point, if you're not treating the disease, you're treating the symptom, right? So I'll tell people all the time here, if the treatment for pneumonia is not Tylenol. The treatment for fever is Tylenol. But we actually want to treat the pneumonia, right? We want to treat the underlying problem. And so we've actually started on a journey for diabetes. And so I asked the hospital to flip around its view and say, what is the hospital's responsibility to every diabetic, right? Not what does every diabetic need from the hospital, which is normally what we think, but instead to say, no, what's our obligation, right? If our obligation is that we want to make sure that everybody has equitable, high quality healthcare, understanding that people come from, we're a safety net hospital, people come from all walks of life. What do we need to make sure every diabetic knows? Well, we should probably make sure that they do have some understanding of their disease, right? Right now, education happens in all kinds of different ways. It's not standardized. I don't know. Some person got a great education from a healthcare provider. This person over here, you know, we did, right? We just kind of dropped the ball. So, but then, one of the things I started to challenge the team on was, okay, well, it's not just about creating an educational package. We have to get it to patients. It has to be in a way in which that they can understand it in the right language, the right culture, the right context. But then I, I, I hate this idea that the patient bears the burden of everything, right? So the patient's going to navigate the phone tree and get an eye appointment. Like, that's crazy. We know who the diabetics are. We know who got an eye exam and didn't. We should own calling the patient and helping them be successful, right? That's a high quality, equitable system instead of just saying, well, it's on the patient. Well, right? That assumes that they've absorbed a transactional, rational status of, I know the probability of me getting diabetic retinopathy and going blind. No, nobody knows that, right? We need to instead go out, nudge, help support, get that a problem solve. Why can't you get to the eye doctor? Right? Is there maybe our hospital doesn't have an eye doctor close to you, but maybe there's somebody else. Let us help connect you. We need to reinvent the way we interact with patients, and it's got to be around behavior change, and it's got to be more supportive and inclusive than it is.
I love that, man. Yeah, I reminds me of two things. One is, I was lucky enough to could go to DC a year or two ago to participate in this forum the National Academy of Science, Engineering, and Medicine did on follow-up care for traumatic brain injury. And just the fact that a lot of these folks ended up having these acute incidents where they were in a car accident or they got tackled in football or whatever, and they had a concussion or they had whatever, and they were treated and then they were released and there was no firm follow-up care plan because the symptoms were gone. But then sure enough, 6, 12, 18 months later, people would start getting headaches. People would start suffering from depression. And when they started getting the mental and emotional effects of the TBI, they became less likely to follow up with their healthcare provider because they were getting sucked down into the muck and the health system had lost their tether. So these folks were just floating out, and God knows if you're suffering depression, like what that can lead to, right? Um, so how am I keeping that tether and that personalization such that, I can ask somebody like, as opposed to just asking for their birthday and their social security number, I can be focused on like, Doug, how are you? I know you went through this traumatic incident like a little over 6 months ago. How are you feeling? And just shut up and like and really absorb that. And the interesting part too, right, is like for some of those things, it doesn't necessarily require a clinician, right? Like we can do that certain follow up without a clinician, just with someone who cares. And then the other thing that makes me think of is Guthrie out of Sayre, Pennsylvania. They've created this pulse center. It's really interesting. It's this kind of extension of an access center where they're kind of building the different parts kind of in a connected fashion where they're connecting telehealth and they're connecting this. And it's just the way that they're trying to build out that connection throughout the continuum, and it's still a work in progress, is really cool. Like I think that's where I see healthcare going in the future, and getting the basis such that then I can work on the front end in a more preventative fashion. And I think that for me personally too, as a patient, the more personalized my health system can be in their outreach to me about what I need to be doing to keep my health
Right.
going and why, the better. Like I'm 37. I think it was like I just met with my primary care physician like a couple of weeks ago. And she's like, "You're gonna need a like colonoscopy in a few years." I was like, oh, "All right, great." Like, but now I know, and I know that like when you hit 40 or whatever it is, like that's just what you got to do.
Yeah. So I think it's one of the things that we did, whatever, in the last year, I would say, we started, so kind of back to your proactive piece, right? 40% of diabetics statistically on average have major depressive disorder. Not really clear if that's due to something biochemical, if it's due to the fact that it's just situationally really depressing to be like, oh my goodness, I've got this lifelong disease, you know. So whatever the cause, as you pointed out, if someone's depressed, they're withdraw, disengage from healthcare, right? Disconnect. And so my challenge to the team was like, look, if we know that diabetics have a high probability of having depression, are we screening all of the diabetics for depression? When a diabetic disconnects from, if they miss a refill, are we proactively reaching out to that person, right? If we're framing this not as, well, Doug just stopped his meds, it's his fault, right? Kind of the traditional blame other people. If instead we turn this around and say, something's happened, and it could be something medical, right? Because often we also think maybe, okay, well, maybe it's the social determinants of health. Maybe there was a copay problem. Maybe there was a whatever problem, all legitimate problems, all of which the hospital should try to help address. But there could also be another medical problem, right? And it might be, you know, Doug's depressed. We need to connect and we need to screen him. Maybe he needs help. And it could be medication help with depression. It could be therapy. But to your point, too often healthcare is sitting there waiting, but the future needs to be, how am I being proactive? And then technology gives us really novel ways in which to start thinking about that, right? I'm always amazed at how nice chatbots are to me compared to the human that I talk to when I call in someplace.
It's so funny that you mentioned that. Dr. Stephanie Lair has some studies showing that, like, because a lot of the times you'll hear, how are bots going to be empathetic? She has a study showing like the empathy of virtual bots and AI versus some traditional, just
Yeah.
people
Yeah.
working in an access center or otherwise. I
Because the
mean,
bot can
the other
spend as
thing,
much time as they need, right? Like it's not on a time
right,
clock. It can be
right,
patient. Like it's just sitting there.
yeah,
But where
and you
could
could
that
just
be proactive, right? You missed your refill. What's the immediate reach out? Do we wait for a human to get free to begin a reach out? Or is there some kind of automatic reach out? Hey, just checking in. Are you okay? Is everything all right? I see you missed your refill, right? Because as you're talking about it, the person, the human being is looking for connection. And I've heard it too often in safety net systems where the patient says, well, nobody called me. I missed my appointment. I missed it. And the system may have actually tried to call, but it can't try infinitely. Bot can kind of infinitely reach out to you, right? So where are the ways in which technology, instead of focusing on the transactional aspect, and I'm not saying that there isn't a need for transactional, I'm just saying, where can it help build relationship? Because if the patient is, man, I missed it wasn't even 24 hours and I was getting messages about this and they're framed appropriately, the person can interact with them however it's designed. But if I feel connected, maybe I should, that doctor cares about me. It goes back to my Hep C patient. He knew that I had his best interest in mind and I wanted to help him. He trusted that and he was willing to do treatment and get cured. But if I didn't have that relationship, he would have been dismissive of me because it wasn't about the probability of cure and the possible benefits of cure. It was all about the relationship for him.
yeah. I mean, and I want to learn a little bit more about some of the initiatives you guys were working on at MetroHealth and stuff like that. But I mean, this has been so good. The last thing, because you brought up and this is all working towards evidence-based care, right? In my
Okay.
opinion, right? And one of the things that I mentioned, my mom's nonprofit, like they're very big on evidence-based care. They have a partnership with Rutgers and I actually want to start working with some of the Northeast health systems because we're talking with HIMSS about their AI Center of Excellence and what we might be able to do to impact maternal mortality rates, particularly for African American women or other marginalized populations. And my mom, with her research, has evidenced the fact that upwards of 80% of those women suffer from either mental health or substance use disorder, and it's not being treated effectively currently, right?
Right.
And that's a real problem, on so many different levels. So it's like it's not just like that's the we have to impact the root versus the and I'm really passionate about that because I think it affects so many communities nationally, and it's not talked about enough.
Yeah. No, I think it's super important. Yeah, it's interesting. So cognitive behavioral therapy, there's manualized programs that folks have developed. And I know Kathy Carroll years ago was working on this at Yale and basically trying to create a computer interactive program where a patient could sit down. And of course, computers are a lot smarter than they were back then. But it would be really fascinating, right, to think about how could the patient be screened, identified as having depression, and immediately be connected into something. And I'm not saying that a computer program can replace a human therapist, but when you think about the shortage of mental health providers in America and the huge burden of mental health disease, even a program that could begin a CBT process and start to screen, right? I mean, one of the things that it's, so I like to tell the subspecialists here, right? My goal is not to give every patient with a pair of eyes to an ophthalmologist, right? Because the ophthalmologist, and they've divided the eyes, so the retina doc needs to see abnormal retinas to do surgery to help that patient. I'm not going to send an 18-year-old with normal retinas and who needs glasses to the retina doc, right? That's a misalignment of resources. And it's not, I mean, I don't think it's a good use of resources to send every depressed patient to the same level of therapy when some of them would have been fine, with a manualized process for CBT. I need to send the person that won't work, right? Oh, you really need to see an actual therapist, or it's not actually, major depressive disorder. You have bipolar disorder. You're going to need some medications and some specialized therapy to be able to have a system that could be deployed and help us triage, like helps everybody some triage to those who are more complicated and escalate them to an evidence-based program would be fantastic. And it's interesting to me that people are scared of those kinds of things, but I have to remind, our hospital and other hospital systems that, wait, right now, what do? You're not screening all the people that need to be screened. And the people you have screened who have a problem are waiting in line for an appointment. And, you know, I was in research for a long time. So I'll say, what you've done is you've randomized them to placebo, right? They're waiting for an intervention, but they're not getting anything while they wait. Now, people might say, well, I gave him an SSRI or he's on some medication. And yes, that can be helpful, but depression is complicated. There's a biochemical issue, but as we know, there can be a lot of trauma, life-related issues, things that you need to talk about. And medication and waiting in line doesn't help with the things that you need to process through therapy. So, yeah, I think the ways in which we could start moving in that direction as well be super helpful as we try to make sure that nobody gets left behind. And sometimes people get left behind because we just don't have enough resources. And where technology can be an added resource, that's a huge value add to people.
Yeah, agreed. And I think that it also needs to start earlier. And what I mean by that is a lot of the imprinting and the trauma or what have you starts early, 5 years old, as you're becoming a young adult into, so how am I like when that and the truth is that student, that 12-year-old student, right, who's going home to, a traumatic situation with one or more, like two parents, whatever the situation is, they can't talk about it there, right? So how am I better arming like the teachers? And like I'm not saying like we don't expect the teachers to become clinicians, but how am I teaching more educators about trauma informed care and how to engage, how to see the warning signs? Because if I can treat that child before they develop substance use disorder, that's going the layer deeper, right? It's affecting things on an exponential level because it's not only that child, it's generations to come, right?
Oh, totally agree. And I mean, so some of what we're trying to do in that space is have partnerships with schools directly. And so in some places
Wow.
we send people to the schools. We have a clinic sitting in a school. So a lot of that's trying to provide for the physical and mental health needs of students. But to your point, right? Oftentimes it's when things get really bad that people start to notice. But usually a lot has gone on to get really bad. And the more, I used to say when we're doing a lot of harm reduction work was, our goal is to get people before they put a needle in their arm, right? Because I don't want, or if they're going to put a needle in their arm, that it's a clean needle. Because there's a whole lot of downstream consequences when you get Hep C, you get HIV, you get other things that become more and more complicated to treat and have their own biological consequences. And so, to the same point, it's easy to be like, oh, well, we don't want people to get viruses. But if you think about trauma and being depressed, they have their own consequences. And there's a lot of human suffering that goes on that's just masked by the fact that we don't have time for each other and we're in these transactional relationships. But the more that we can start to identify people and then connect them into care, and the earlier we can do it, the better, so that we can try to really avoid that young adult seeking to self-medicate depression with a substance then leads to a problem. And then, you know, a decade or more later, after having significant consequences to the substance use, winds up somebody trying to help them with that, but then maybe missing the root cause. And so I think there's a lot in this space. And the more that technology helps us identify populations that need help and help prioritize those populations so that hospital systems like safety net systems are able to prioritize and understand, well, I mean, I've got 47,000 diabetics that I need to make sure all of them get an eye exam this year, that all of them get a foot exam, that all of them have a hemoglobin A1C, that all of, but it's very challenging to know where all of those people are all of the time and to know where they are in the continuum of care and where we can actually intervene. I've got limited resources. So what's the technology that helps me manage a big ocean of people and then flag those who need individual human attention so that we can make sure that we're, connecting the right patient to the right person at the right time.
Right. And the tricky part, it goes back to what we said, like a lot of those factors that I would want to incorporate in that understanding of a patient in order to prioritize them effectively and support them appropriately do not necessarily live in the EHR today. So how am I, augmenting that? And what certain EHRs are doing now with CRM as an extension of the core functionality is solving for some of that. And, it's an evolution, but um, yeah, really interesting stuff. I mean, time has flown, Chuck. This is awesome. I do want to ask. I always like to ask what favorite book or a book that you've read recently that you might recommend to our listeners. It could also be a podcast or other type of literary piece. Again, either all time or recently, your choice.
So, Fried and Heinemann from Basecamp wrote a book that they published relatively recently called Things Don't Have to Be Crazy at Work. And so, they're at Basecamp. And so their argument, which I found fascinating, because I don't think of the tech industry as arguing for a 40-hour work week. And certainly medicine's never argued for a 40-hour work week. But they had this fascinating argument that so much of our lives are interrupted by technology. And because we get interrupted lots and we get interrupted at work, whether you get a, instant message from somebody about this or an email or, you get all of these things where you're supposed to be constantly available, that you can't get into the flow of work Um, and, there's a whole body of literature on flow, but that idea of I need a couple solid hours where people don't bother me so I can actually make progress on things. And I would say since going through that book, I have just been paying attention to a lot of the meetings that I get sucked into where I'm like, why? Like, why are we meeting? Could this have been an email? Like, what's going on here? And, it's interesting because it's almost like people are using the guise of some transactional thing. Like, we need to get together to do X when X doesn't seem to be what the meeting's about. It seems like we're kind of having just a relation conversation, right? And I'm not saying relationships aren't important, but the reality is, yeah, I'm not getting anything done. And now I'm more stressed. And now I've got all this other junk to do. And so I would recommend that to people. You may or may not agree with all of the premises or arguments, but it's just really fascinating to hear of a group that for the last 20 years has made having calm be something important at work and and providing people with space to really get into the work and to do it well. And it's made me start thinking more and more about how we interrupt physicians and nurse practitioners and PA, other people when they're trying to do their documentation, right? We interrupt them. You're trying to chart and we send you secure chat through the EMR and you're like, oh, now I got to deal with this and I can't, or they get a call or a page or someone knocks on the door and you can never pick up where you were. Like an audiobook, you're like, okay, I gotta have to rewind and then have to re-listen to this in order to figure out where I am. And so
Right.
we're
It's
and we also
inefficient.
we're inefficient and then we miss things. Cause like, well, I interrupted you when you were thinking about I needed to order this lab or do this imaging or do this referral, and then I forget. Or I'm asking the patient,
Yeah.
hey, do you remember what I was doing? And that impacts the
That's
quality of care. And so I just found that more and more interesting of how do we start protecting the provider's time? And so we've actually started talking about right now, a lot of the healthcare providers here have kind of charting time spread out throughout their day in which they're doing care. And so I'm starting to make the argument that I want to pull all of that out, give blocks of administrative time, and just say, look, be off campus. I don't care where you are, but you need to have some protected time so that you can be efficient and you can do the clinical documentation work you need to get done. You can really reflect on the care of the patients that you're taking care of in a way in which you're not being interrupted by just the helter-skelter nature of a hospital system.
mm, that's super cool. I mean, I love that, and it's true for me. It's something that I've had to look at. Basecamp is like the project management collaboration software tool. Is that right?
Yeah.
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 I got to check that out. But yeah, this is how I build my reading list. So, Doug, this has been awesome. We're pretty much out of time. The last question I just like to ask all my guests is if you could go back 5, 10, 15 years in time, what advice would you give your younger self?
I think I would tell my younger self, focus on the doing good and take more risks. Right? There's so often times where I would say I was overthinking the situation. And I feel like if I hadn't been I was making the perfect the enemy of the good. And if I just focused on this is good enough, work that like do just get this launched, take some more risks. Feel like we could have done more good. That's what I hope to do in the future.
I love that. That's I feel like that in essence is the root of innovation, really. Is being willing to having the courage to take that risk, which for me was similarly gained through time and perspective and all of that. But then, incorporating that feedback and then moving forward to the next iteration, right? And I'm seeing more and more of that in our industry as a whole. It's a slow roll, but it's really exciting. And clearly, you're on the forefront of it. So, Doug, such a pleasure having you on. Thanks so much for taking the time.
Thanks for having me. It's been great. Love the conversation. Always love chatting with you.
Yeah, me too. And to our listeners, thank you for tuning in. We will catch you all next week.